Next up, we are calling on experts for a deep dive on key pillars of healthcare, affordability, and access. Please welcome on stage Michael Chernew, Professor of Healthcare Policy at Harvard Medical School, Jeff Myers, President and CEO of Medicaid Plans of America, Kristen Manzalillo, Senior Director of Global Policy at Pfizer, Gary Puckrin, President and CEO of the National Minority Quality Forum, and Donald Dempsey, Vice President of Policy and Regulatory Affairs at CVS Health. The Hill's healthcare reporter, Rachel Rubine, will be leading this conversation. Rachel, over to you.
Hi, thanks so much everyone for coming, and special thanks to our panelists for being here. We have just about 35 minutes, a lot of ground to cover, so just want to dive right in. It's no secret that there are concerns about the rising price of prescription drugs. Would like to ask Kristen a question. Pfizer is a company that has increased some list prices of drugs, so would like to talk about any steps the company has done to increase affordability, transparency, and just also how the healthcare system as a whole could try and do this to help make drugs more affordable.
That's a great question. Thank you so much for convening this panel. At Pfizer, when we make pricing decisions, we take an approach that we think is responsible, that's appropriate, and that really considers the value that the medicine brings to the patient and to society overall. We think that medicines are one of the most efficient ways that we could spend our healthcare dollars in this country and throughout the world. They're the only part of healthcare that has built-in cost containment. I think statins are a great example of this, for instance. Since 2005, the price for statins, since they've gone generic, has decreased by 95%. And this has generated over $1.3 trillion in value to the healthcare system. We see then we have these innovative medicines as well, which are, in certain instances now, providing cures to disease. The cost offsets to that are huge when we think about hepatitis C, for example. In terms of improving affordability, I think medicines offer the opportunity to save in other parts of the healthcare system. I think we need to work to make sure that patients have access to these medicines. So we know that adherence is really important, and that as out-of-pocket costs get raised for medicine, adherence declines. That could affect health outcomes for patients, and that could affect long-term financing. So we need to think about solutions that help to improve the affordability of medicines for patients when they have insurance. Things like limiting out-of-pocket exposure, things like making sure that manufacturer-negotiated rebates and discounts could be shared with the patient as well.
Don, I'd love to hear a little bit from the pharmacy benefit manager perspective.
Sure. Well, of course, our job is to help make medications more affordable. And, we do that through our size, our ability to negotiate with manufacturers to help lower those drug costs. And, we certainly, when it comes from a DC perspective, we think competition in the market and how it works really right now is very good, but there are some areas we could, government policies that could be sort of improved. Focusing the FDA on approving generics when brands are coming off patent. Focusing the FDA on approving generics when there's only one generic in the market, because the addition of a second and third generic really drives down costs. So, there are definitely some policies that can occur that would certainly be beneficial in helping drive down drug costs and increasing accessibility. But of course, there are things too in the market that we're doing, or relatively new policies we've adopted. For instance, we do point of sale rebates for our commercial clients. We offer that. For any of you that may work up in Congress or the federal government, if you're a part of the Blue Cross Blue Shield Federal Employees Program, you may not realize this, but you get point of sale rebates when you go to the pharmacy counter and you're purchasing a drug. So this is something we do offer our commercial clients if that's what they want to do. It's a choice. And of course, it's a choice for them, something that they have to weigh off, right? Do they want to do that, or do they want to use those rebates to lower, their employees or beneficiaries' premiums? But it is something we want to offer them. So, we think trying to continue to innovate that way and providing our clients more choice is also something that's very important.
Mm-hmm. Any proposals on the Hill that you've been working on?
Well, one thing that to go back to sort of the point of sale rebates and commercial plans, another issue that I think either could be done administratively or through legislation deals with health savings accounts and high deductible plans. Under current law, health savings accounts, the high deductible plan associated with them can cover preventive benefits with first dollar coverage. So you don't have to use money out of your health savings account if you're getting some type of preventive benefit. The health plan can cover that. And under that, there are drugs that are covered as part of that. But, the rules around this are a little bit ambiguous. It's not like the IRS has specifically provided a list of drugs. In fact, they really couldn't because, a new generic might come on the market that might fall in that, something like that. So they would have to continually update that list. So there's been proposals to sort of expand this to cover more chronic conditions. And frankly, we would take it even a step further. Just say, look, allow the high deductible plan to cover drugs however they want. Just give them the option. They want to have first dollar coverage for drugs, then let them have first dollar coverage for drugs. Probably if you gave them that option, you'd have more coverage of generics at the first dollar and probably some brand. And it would sort of remove the uncertainty over the current rules. So that's something we're certainly supportive of and have been, meeting with both members of Congress and the administration on it.
Mm-hmm. Kristen, you mentioned value. Michael, I'm curious your thoughts on just kind of the state of where we are in implementing value-based care over volume. What challenges, barriers exist?
Well, that's much broader than drugs, obviously.
Yeah.
I think we're moving that direction, not because it is such a wonderful direction to go, but frankly, the existing system has been on a path that hasn't been sustainable. And so we're a little bit of push towards that direction. I think the path we're on is sort of slow and steady progress, and there's a number of bumps in the road and regulatory tweaks I think we need in Medicare, some things going on in the private sector, to broadly promote that path. But I think what people are beginning to realize is that we need a system that treats a patient or an episode broadly as opposed to focusing on a particular type of treatment like drugs or hospital care or outpatient care, and understanding all of the tools that might be brought to bear. And some of them are not traditionally those thought of being inside the healthcare system, for example, to try and do that. And I think that the only way we're going to be successful with an affordable, high-quality healthcare system is that we can allow the delivery system broadly to efficiently manage all the resources at their disposal in order to provide the best care they can within a somewhat fiscally sustainable budget.
Mm-hmm. And Gary, I'm curious, we were talking a little bit backstage about rural, minority communities, underserved communities, and just how important you see making sure care, drugs are accessible. For background, I worked at a community newspaper that only had one hospital in the county, and kind of imagining that hospital not being there would mean people would be driving 45 minutes, an hour for care. So can you expand upon that a little bit?
Surely. I think in a lot of ways we're asking the wrong questions. I think in the 21st century, we're really thinking about sustainability and controlling health outcomes. A lot of the value discussions that we're having today is about the present. What are we getting in return in the present sense? What we're not appreciating is that we're laying down infrastructure, meaning that we are taking on the challenges of chronic diseases. If you look at the trend lines for cardiovascular disease, HIV, cured hepatitis C, that's where we're moving towards in the 21st century. And it takes real investment to do that. And the fear is that as we try to meet these present concerns, that we destabilize our ability to aggressively move forward. Where we want to be by 2050 and 2060, we want to control health outcomes in our communities. We don't want this randomness. We don't want medical deserts. I mean, what you're talking about are communities right now in America where essentially they're medical deserts. Their access to quality care is poor. Their access to physicians, to appropriate therapies are poor. That's not the system that we want. And so I think we have to reframe this conversation a little bit and understand a little bit deeper what we are investing in And if we limit the conversation to the present tense, then I think we're going to fail, because what we're going to do is we're going to slow up our ability to innovate. And I would argue that we have to learn how to innovate very, very quickly and be able to disseminate health information very quickly across our populations.
Mm-hmm. And Jeff, Medicaid comes in as serving vulnerable populations. How do you think Medicaid health plans can help with that?
Well, it's an interesting conversation. You started out talking about the cost of prescription meds and what that means for affordability. 1/5 of America, 1 in 5, get access to health care today via Medicaid. Medicaid as a program is, without a doubt, a program that is a high-value, low-cost design. 75% of those in the Medicaid space are covered in full-risk managed care plans, where the margin, according to the American Academy of Actuaries, is 1.5% for nonprofits and 1.8% for profits. So it is very efficient, and it covers the sickest Americans. When we look at some of the affordability issues and some of the access to rural communities, to communities of color, and to underserved populations, what concerns our plans is that, not to be a skunk in the garden party here, but that there are 3 big drivers of cost. One of the big drivers is the way we provide for long-term care services in America. That needs to be addressed. 2/3 of nursing home payments are made via Medicaid, not Medicare. Behavioral health and the way that behavioral health gets integrated into physical health is a very high cost driver that isn't being addressed today. The third big issue is drug costs. Medicaid enrollees are by far the sickest part of our population, but the spread, the sickest part, the dual eligibles, are actually getting drug coverage under the low-income subsidy, the LIS, and not in the MDRP. And from our point of view, the drug rebate program, which was established in 1990, actually causes drug prices to go up, not down, paradoxically. And it drives costs to state and federal taxpayers. And what we've seen in this debate that's happening in the Senate is a realization of something that I think everyone in this room, because you are healthcare experts, knows too well, that the ACA, for all the argument about the exchange population, was actually an expansion of Medicaid. 2/3 of the individuals covered under Obamacare are Medicaid enrollees. And so not only did you see a growth in the population of Medicaid, but you've seen a dramatic increase in the price. And one of the ways that that price is being escalated is the way in which Medicaid buys drugs, and it impacts every other part of the US health system, because 1 in 5 Americans now get their access from this. So we're shopping a proposal that would leverage the value of managed care plans, plans that take full risk in the space, to negotiate directly with drug manufacturers, because the plans, unlike every other segment of healthcare, own the full risk. Unlike commercial, they can't just change the contract and say, I'm not going to cover something, it's not a service I provide. That service is already built in. So plans have an incentive to make decisions about drugs that actually reduce total cost of care. Maybe they buy more expensive drugs to reduce time in the hospital. Maybe they enter into a value-based purchasing arrangement where the drug companies actually take real risk in servicing the population and not just a rebate risk. And those are the kind of things that I think over the next 24 to 36 months, you're going to see some real development in.
Kristen, do you want to weigh in on the proposal Jeff is shopping around?
Say that from Pfizer's perspective, our priority is making sure that patients have access to the medicines they need. Mm-hmm. So we would want to make sure that any sort of proposal that's out there right now allows the physician or the provider to have the choice to prescribe the medicine that's most appropriate for their patient. We think, of course, that benefit designs and plan designs that drive utilization to high-value services and treatments, whether that's medicines or other healthcare services, is critical. That makes sense from a cost perspective and from a patient health perspective as well.
Mm-hmm. And you mentioned the Affordable Care Act and Medicaid. Medicaid's been such a thorny issue in trying to repeal and replace Obamacare. Michael, I'd be interested in learning a little bit more from you. You had a New England Journal of Medicine article that I read that talked a little bit about improving the value of Medicaid and how that's been something that's kind of been lost in this debate. Do you mind telling us a little bit more about that and what that could do?
Well, I think Jeff explained it pretty well, to be honest with you. I think the spirit behind what we were writing was broadly consistent with what has been said. So we're very supportive outside of Medicaid in the type of proposals where high deductible plans could be used better in terms of cost sharing. Within Medicaid, there's the Medicaid managed care plans, which, as Jeff mentioned, are crucial because of their flexibility. We were thinking about other types of models in Medicaid where the risk gets allocated in a different way. In Oregon, for example, they have CCOs. I wrote that article with John McConnell from Oregon. And I think the theme that's broadly going on in health reform is who's going to bear the risk for higher spending, and how are we going to deal with the fact that we want the value associated with new innovation and new services, but we're hesitant to figure out who's going to pay for all of that. And so we are exploring through Medicaid managed care plans, through new Medicaid payment models like CCOs in Oregon, through new arrangements like high deductible plans for the commercial population where more risk goes on to the patient, and to a range of things in Medicare to figure out where that risk goes and how it plays out. And I think in all of those things, we talk a lot about moving from volume to value. I think that's just a misnomer because people like the word value. First of all, it alliterates with volume, so that's nice. But more importantly than that, what I think is really going on is we're moving from a volume-based system where the risk is typically borne, say, in Medicare or Medicaid by the ultimate payer, to one in which the risk is getting transferred down to, largely speaking, providers, sometimes in certain value-based arrangements to drug companies, sometimes to other organizations. But it's really volume to accountability is probably a better name. But since that sounds so bad, and I feel poorly because I'm on TV saying it, I'm going to stick with volume to value. But I think the value is really sort of the word sugar that makes the medicine go down. It's really about moving accountability and risk to other parts of the system and giving flexibility within that for people to manage appropriately.
Mm-hmm. Do you or Jeff have thoughts on how to move that, and what proposals, or if there are proposals out there that would do that?
I personally think that in Medicare, you're seeing a lot of that through CMMI, and I really hope that that general movement continues. In fact, I think broadly there's too many of those types of models in Medicare, but you'll see a continued move, in my opinion, towards ACO-type models. There's the OCM model, which is the episode-based payment model for cancer in Medicare, for example, and I think you'll see more of those types of things go on. I don't think you necessarily need new, big legislative proposals to make a lot of these things happen. I actually think we have an infrastructure that can allow Medicaid managed care plans to succeed. I'm sure we can tweak it. There's a lot of regulatory tweaks in Medicare that could be done. I'm a big supporter of the idea of allowing high-value health plans, which means you can cover certain chronic care medications as preventive services under HSAs. But we're getting pretty close. I think we're in a stage where we just need to execute better.
And I would say this, I mean, I think we have two questions that face policymakers today. One is almost ontological. If you think about the Hep C medication, when Gilead came out with their drug, they said that the high price would reduce liver transplants and that we needed all the future value of savings today as present value, and that you'll get your savings back sometime in the future because you're going to reduce liver transplants. 3 years in, if you look at the UNOS data, which looks at transplants in the United States, are liver transplants up or down? They're up. They're up 9%. So we've spent all of this Hep C money on drugs, but we haven't seen any return yet. And that's not necessarily a bad thing, right? People needed to be cured from Hep C. It's a very serious disease. But the pricing model that pharma has adopted doesn't actually work going into a value-based arrangement in the future. And so I think on the ground, one of the things that needs to be done is real consideration of how do you align the profit incentive for pharma, right? Because they're taking very big risk. It is very difficult to make a drug in a way that aligns with the pricing needs of society. And if you use the Hep C treatments and you look at Gilead's pricing model, it clearly was not that. And I think you're going to see more and more of that in the future. So my view is, first you have this universal view of what you're actually willing to spend on healthcare. And then secondly, looking at it from an efficiency side. How can you align the folks that are taking risk with the services provided. And Medicaid is unique, as I said earlier, in that plans take full risk and can't change the contract design like you could in commercial, for instance. And that contract design requires the plans to really think through what are the services that I can provide that actually bring down the total cost of care that meet my contractual requirements for quality metrics and other items. And I think you're going to see the Medicaid chassis begin to be used more and more. It does not surprise me at all that states like Nevada have seriously thought about allowing the near poor to buy into the Medicaid program, because the structure of Medicaid is actually relatively sound. Now that it insures more people than Medicare, and the states all have this ability to kind of move around and try and figure out what works best for their states, I think that model design you're going to see more and more, and I believe you're going to see some of that structure actually make its way into commercial as well.
Mm-hmm.
I think one of the things that sort of a more focused policy you could look at in trying to get more adoption, say in Medicare, of value-based purchasing with drugs is looking at the anti-kickback statute. Because it's really hard to think about ways to incentivize beneficiaries to make sure they're refilling their prescriptions and things like that, and incentivizing them under the current rules. And, you know, allowing some innovation in that area, testing some models, might be really useful in seeing can we get higher levels of adherence and those type of things. So, I mean, I think that's something that needs to be looked at.
Absolutely, I absolutely agree.
Yeah.
Absolutely.
Sorry, Gary?
Yeah, I listen always to these conversations about value, and I think about them from the patient's perspective. And one of the things that we're not doing in our system is that we're really not being transparent about what is the outcome for the patient. What is the risk for hospitalization? What is the risk for dying? What is the risk for going to the emergency room? And are these various proposals, are they elevating that risk? Are the risk remaining the same? Are they improving? And so, you know, we have to be careful when we do these, begin to set these models up, that integrated into the model is transparency about the outcomes for patients. Because at the end of the day, that's really what we're trying to do, right? We're trying to reduce risk for patients. And so I'm always careful in watching when I look at these models and proposals, you know, I think of some of the work that's coming out of CMMI. I don't see the transparency about the health outcome for the patient. And at the end of the day, these models go into the clinical setting. They're there, and they are helping to direct care. So I would urge us all to think about that a little bit, and how do we build into the system that level of transparency so that we know that the dollars that we're all paying for healthcare are actually bringing the outcomes that we're looking for. Just quickly, if you look at the minority community, for example, the level of outcomes, just saw an article for African Americans with heart failure, the hospitalization rate is 240% higher than whites. 240%. That's an astronomical number. And we're not doing anything about it, and we're not measuring it, and we're not changing it. That's the kinds of things I'm talking about. If you look at rural communities, you think that 240% is high for African Americans. It's even higher in rural communities. So we're leaving large segments of our population out because we're not measuring, we're not reporting, we're not giving that transparency that the American public needs so that they understand that the dollars that they invested in healthcare are actually delivering to them the quality of care that they're paying for.
Rachel? I'm sorry, can I jump in to respond to what Gary said?
Go for it. Yeah, go for it then, Kristen.
Two quick things I would say. The first is, I think the evidence suggests that all these new payment models are lowering spending, but just by a bit, and improving quality, but just by a bit. And the more we can build upon our existing quality measurement infrastructure, the better we will be able to create the transparency that Gary was talking about. And it's going to be more than measures, it's going to be measurement systems, and we really have to think about how to understand and measure what we ultimately want.
I would echo what you said about keeping the patient really at the focus and at the center of any proposals or changes that we're seeing. We need to move to a system really that is more patient-centric. We need to think about a system that is accessible for all, so that the coverage that is being provided, whether it's through public programs or through private plans, is actually meaningful and people could utilize it. We need to think about a way where we increase the emphasis on prevention right now, where we're rewarding these patients for healthy behaviors and also finding ways, I think, to incentivize providers so that they can better manage risk over the long term. The same goes, I think, with measuring value, your favorite word, over the short versus the long term as well, right? We don't have a way, I think, right now where we could value a Hep C medicine for the savings that it may generate down the line. So I think these are components when we're thinking about how to evaluate proposals. We could keep these components in mind when we're trying to keep patients at the center of it.
And Gary, keeping the focus on the patient and the patient wanting to know what the price is going to be, are there any proposals, bills, et cetera, that you've seen out there from the patient perspective that achieve this?
You know, that's a really difficult question. I think my short answer would be probably no. That I think the patient has been on the sideline in a lot of these discussions. Everybody talks about being patient-centric. I hear that all the time. But when you actually go in and you take a look at the policies and how the policies are aligning with patient outcomes. So my classic example is health policies do not have to follow clinical guidelines. So we have these clinical guidelines that tell us how to approach appropriate therapy for patients. And so if everybody's operating at the top of their license and we're following those recommendations, we should get the best possible outcome for that patient. But when you write a policy, you don't have to take that into effect. I mean, you literally don't have to say, so what does the clinical guidelines suggest that this policy should be aligning to and driving? And that's a fundamental problem, right? And so there's lots of places within the system where you see this breakdown between what we understand to be quality care and what we're prepared to deliver as quality care. But the most important part of it is you, the public, don't have the transparency. You don't actually know. You think you're getting quality care, but you cannot go to any place to say I'm absolutely certain that I'm getting quality care by guidelines. And I think that's really important.
One of the things we're working on, a technology we're working on, is really trying to integrate the drug benefit into the electronic health record. And what I mean by that is when you're in the doctor's office and the physician is prescribing you a medication, that the physician will be able to tell right then and there, is this medication on formulary? Does this medication need a prior authorization? If it needs a prior authorization, the physician can do it right then and there. Is there a cheaper alternative to this medication that's basically equivalent? What is the price of this medication going to be when the person goes to the pharmacy counter? You know, right now, of course, a physician may prescribe something and it may not be the drug on formulary. There's an equivalent drug on formulary. The beneficiary goes to the pharmacy counter. The pharmacist says, you know, you don't really want this drug. It's going to be very expensive. There's this other drug, but we have to call the physician. We have to fax them. Many calls and faxes are sent back and forth. It may take a week. You know, maybe the beneficiary doesn't come back. You know, so there's a lot of problems there, and we're going to be rolling out this, you know, sometime late this year, maybe early next year, of saying, look, you know, adopt this technology. Hopefully physicians will use it. And, you know, we can solve a lot of this in no more faxes and phone calls and really minimize that and let the beneficiary know this is what I'm going to be paying. This drug's covered. I don't have to worry about it anymore. When I get to the pharmacy counter, I know what I'm getting.
And we're going to go to audience Q&A in just about 2 minutes, so be thinking of your questions. Just want to turn to news of the day real quick. We have a lot going on with Obamacare repeal and replace. We're kind of waiting to see if the Senate will pass something, and if they do, what it will be. There's a chance that they could pass a skinny repeal bill, which wouldn't include all of the Medicaid changes that have been contentious, at least out of the Senate side. And so, Jeff, I'm curious to learn a little bit more. Medicaid Health Plans of America came out against the House bill for federal reductions in late March. I'm curious what changes to Medicaid you guys would like to see specifically?
Well, the good news is that we actually agree with the majority that the Medicaid program today is not fiscally sustainable over time. You have to do something for this program. The question is, how do you do it? And I think from our point of view, a 26% federal reduction would destabilize the program. And it isn't just our view. Governors view it that way, and so do others. We've worked with both the majority and the minority around a per capita caps model. It is not something that we're opposed to. It does have some internal logic to it. But I think the biggest question that they're going to struggle with in the future is that the fundamental nature of Medicaid has changed. I was on the Hill about 20 years ago, and it was kind of a backwater program that nobody really paid attention to. Now, it is the program that drives healthcare in America. It is, both by size and scope, by populations covered, one of the single most important healthcare programs in this country. And I think the challenge that the Senate is having is the realization that Medicaid, as we knew it 10 years ago, doesn't exist. Medicaid today now has so many more so much more political support because you're covering the near poor, because you're covering the very sick children, because you're covering the aged. It is a middle class entitlement because most Americans can't afford to put mom or dad in a nursing home, so they end up being paid for via Medicaid. And the biggest thing is, it is the largest single revenue source for state budgets. So when you start dialing back Medicaid, it's not just about health care for the disadvantaged. It's not just about health care for communities that don't have access. It's also about roads being built, schools being built, teachers being paid. It has a dramatic impact on state budgets. And so the challenge going forward in the future that we support is thinking about Medicaid more holistically. Are there ways to access services for housing, for instance, because housing and socioeconomic determinants of health have such a big impact on this population, to lessen the impact of reduction, but to phase it down in a way that doesn't destabilize the program.
And that's a great point. It's definitely been on the front burner of Congress now this year, as we've seen. Want to make sure that we're able to get in a question or two from the audience. Anyone have some questions?
Great.
Back there, yeah, right there.
Hello, my name is Jing Wu, and I'm with the American Pharmacists Association. It's been really interesting listening to all these talks because I'm actually a rare individual who lives in the gap that you speak of. I'm a pharmacist, but I'm also a severe traumatic brain injury survivor. So what happened to me is I woke up in a hospital in the neuro ICU, and because of our healthcare infrastructure, I fell through the cracks. And so when I left the hospital, I continued on my normal life path, which was apparently going to pharmacy school. So 4 years later, I popped out and I was a doctor. So I've really been able to see both sides of the spectrum, both empathizing deeply with providers, but also with patients. So I spend a lot of time with pharmacists and other providers as a public health major. But also with my patient population, which happens to be traumatic brain injury, stroke, which segues into epilepsy, Alzheimer's, et cetera. So my question for all of you in your conversations is, I didn't go through the healthcare system the normal way, and a lot of people would argue that I'm doing very well for my kind of patient. And so what I want to explore is, I've been in the pharmacy realm. I haven't heard too much about it. We have reps who are within the pharmacy field, but what is happening to help pharmacists achieve provider status, which I know is HR 592 and the Senate 109, to help fill those gaps in terms of access. Pharmacists are touted as the most accessible healthcare professionals at this moment in time.
So,
Don?
the legislation, and it actually has a significant number of co-sponsors, the last Congress, way more than a majority in the House, that would give pharmacists provider status in Medicare. The problem is the cost. It's quite expensive to do so. And how do we sort of offset that cost? And that's something Congress sort of is going to continue to work on and look at ways to do that. We're hopeful that one day they'll sort of figure that out. But there's a lot of action at the state level of working with state legislatures and governors on, because pharmacists are often the most easily accessible healthcare professional a person's going to see, and the person they see most often. of, allowing pharmacists to do things like provide flu shots, right? So there is a lot of activity at the state level and working and sort of expanding their scope of practice, letting them practice at the top of their license is what we would say.
And unfortunately, we're out of time, but thank you so much, everybody, for the great conversation, and thanks for coming.
Thank you so much to Rachel and to our panelists. This brings us to the end of our program. Thank you all for being here, as well as those watching the live stream. If you missed any portion of the discussion, it will be on thehill.com later today. And just a reminder to fill out your feedback forms, please. Thanks so much. Have a great rest of your day.